So we'll be talking on hypertrophic cardiomyopathy, which we left in last class discussion. So last class was about cardiomyopathies in general. So we started off with dilated cardiomyopathies, and then we went through restrictive cardiomyopathy, and finally we thought we'll have this hypertrophic cardiomyopathy as a separate session, because this is of paramount importance. Whatever you do, whatever exams you take, be it at the postgraduate NEET PG exam or be it at the super specialty exam, this plays a very important role. All this, even a single line in this topic is very important from an MCQ point of view. And even for case presentations, whenever you present cases, especially at the exit exam, this will definitely be kept as a case. And very beautiful discussions can happen over this case. So, hypertrophic cardiomyopathy, that's a new term that is given for this disease. So earlier when we were undergrads, when we were doing undergraduation, we used to call this as hypertrophic obstructive cardiomyopathy invariably. Okay, so it can also be labeled as idiopathic hypertrophic subaortic stenosis, or sometimes asymmetric septal hypertrophy. But now the standardization is, it should be called as either hypertrophic cardiomyopathy with obstruction or without obstruction. So the hypertrophy is common, the cardiomyopathy is common. Hypertrophic cardiomyopathy, either it is with obstruction or without obstruction. So where is the obstruction and what brings on the obstruction? What is the pathophysiology behind it? What are the symptomatology because of this obstruction? And what can you do to relieve symptoms? Is there any preventive measures? Is there anything that can prevent the sudden cardiac death associated? Is all our discussion is about. Okay, guys. So what is the definition? Okay, definition is very simple. Okay, we all know hypertrophic cardiomyopathy. This name itself is very self-explanatory. There is hypertrophy, because of that there is cardiomyopathy. Okay, what happens is the LV hypertrophy that happens. See, I'll write legibly so that I can share this annotated PDF also to you guys. So hypertrophic cardiomyopathy is defined as a left ventricular hypertrophy that develops in the absence of causative hemodynamic factors. So very clearly stated. Okay, LVH that happens in the absence of a causative hemodynamic factors. So what are the causative hemodynamic factors that usually causes left ventricular hypertrophy? Like aortic stenosis, systemic hypertension, or any infiltrative disorders, okay, or any storage disorders. All these can cause left ventricular hypertrophy. Okay, any left ventricular hypertrophy that develops in the absence of all these causative hemodynamic factors is termed as HCM. Whether it is with obstruction or without obstruction is based on the LVOT gradient. So what is LVOT, what is gradient, we will be seeing in pathophysiology. For now, you just need to understand the definition, the LVH that develops in the absence of causative hemodynamic factors such as hypertension, aortic stenosis, or infiltrative or storage disorders. Okay, guys. So this is the gross specimen. Okay, so this is the normal heart. Okay, this is the normal heart. What you find here is the RV, RA, LV, LA. You can find a papillary muscle, all those things. What you find on the left of your panel is a grossly hypertrophied ventricle. Okay, so grossly hypertrophied ventricle. So this is actually HCM. Okay, see, I told you last class when we were discussing on echo discussions, whenever you see a thickened left ventricle, okay, do not call it as LV hypertrophy unless you are sure that it is the muscle that has hypertrophied. So whenever you see an increase in the LV wall thickness, you call it as a thickened LV wall, and then from then on you delineate what has caused the thickened LV. Okay, thickened LV. Okay, here you see such a gross thickening of the left ventricle. Okay, what is there in the histopathology in patients with HCM? Okay, it is very classical and it is even asked as an MCQ question. Histologically, what you find is a myocyte hypertrophy which are arranged in a haphazard manner. See, this is the normal myocytes, okay, normal myocytes which are uniformly arranged. Here it is, you see, myocyte disarray. Okay, this is called myocyte disarray, and in between you also have some fibrosis. Okay, so histological characteristics of HCM is a myocyte hypertrophy and disarray with myocardial fibrosis. Okay, with myocardial fibrosis. This is also an MCQ. Please remember, guys, that disarray is a specific term that is usually asked. Histopathological examination reveals myocyte hypertrophy and disarray in HCM. Moving on to genetics, see, this is the first genetic cardiomyopathy that is studied in detail at the molecular level. Okay, so it is a disease of the sarcomeres. 50% of patients have sarcomere mutation. Among this 50%, 80% have mutations in either of these two, MYBPC3, which is myosin binding protein C3, or MYH7, which is myosin heavy chain 7. Okay, clear, guys? This is first genetic cardiomyopathy which is described very in a detailed way at the molecular level. It is actually a disease of the sarcomere. 50% of the sarcomere mutations are found in HCM patients. Okay, among those patients who are sarcomere mutation positive, 80% is due to myosin binding protein C3 or myosin heavy chain 7. Okay, this is also an MCQ. What is the most common mutation that is involved in HCM? If you ask, it is MYBPC3, which is more than MYH7. Okay, so Harrison tells you that it's these two are most commonly involved in 80% of the patients, but which is more common among the two? It is myosin binding protein C3, which is more common than myosin heavy chain 7. Okay, so what is the prevalence? Don't think it as very rare disease. It is 1 in 500 in North America. Ours is also a very close figure, though we don't have an exact data in our literature. It is 1:500. Among every 500 patients, you have one patient with HCM. Okay, so making it the most common monogenic heart disease. Okay, so single genetic disorder causing a cardiomyopathy. This is the most common monogenic heart disease which is prevalent in our population. Okay, one thing about genetics, it is you should understand it is. So though this is, some of my patients, when they come, I tell you this is a genetic disease. They say, I have done echoes multiple times in the past. Nobody has told me this. Then why are you stating that I have a genetic disease? Okay, though this is a genetic cardiomyopathy, it has an incomplete penetrance and variable expressivity. Okay, it has an incomplete penetrance and very rarely it presents at birth. Okay, usually develops in later life. Okay, so if you have done echo at 15 years of age, at 20 years of age, you would not have found this hypertrophy in your heart, and then at 40 years, if somebody does a screening echo and tells you that it is HCM, it's very much possible. You should understand that it has a incomplete penetrance and usually not seen at birth. Okay, it usually develops at the later part of life. Clear, guys? Clear?